Hello, my name is McKay Raywinkle, and I will be presenting on gastrointestinal complications in the intensive care setting. First off, let's introduce the case study. My case study is a 77-year-old female white Caucasian with a past medical history of COPD, hypertension, type 2 diabetes, hypercapnia, which is when the body has abnormal levels of carbon dioxide, respiratory failure, hyperlipidemia, obesity, GERD, and cervical cancer. The patient presented with COPD exacerbation, showing signs of shortness of breath and right hip pain. The patient was admitted on 2/15/15. The patient was admitted to Winter Park Memorial Hospital, and she had been previously admitted 2 times in the past 2 months for the same reason of COPD exacerbation. It is known that the patient is the sole caregiver of her 101-year-old mother at home, and she is also the mother of an adult independent son. The patient was admitted, and during her initial medical treatment, the patient was in respiratory failure but responding well to BiPAP respiratory treatment. The patient showed chronic right hip pain due to severe canal narrowing with bilateral recess, effacement shown in the lumbar MRI. When the patient was admitted, there was no known food allergies, and the patient's family medical history was unknown. The patient presented with respiratory wheezing and showed that her GI tract was within normal limits, as well as her skin was within normal limits. The patient was alert and oriented ×4. When the patient was admitted, her height and weight were reported. Her height was reported as 157.48 centimeters, and her weight was 68.8 kilograms. Per Winter Park or Florida Hospital's medical records, the patient's last reported weight was 79.3 kilograms. This weight was not in a significant time frame with her admit weight. The patient's BMI calculated to be 28, which is considered to be overweight, and the patient's ideal body weight calculated to be 50 kilograms. This calculated her ideal body weight percentage to be 138%. Her ideal body weight percentage is above 125, therefore an adjusted body weight would need to be calculated for appropriate energy estimation. Now we'll look at the estimated energy needs for this patient. When the patient was first admitted, the patient wasn't admitted directly into the hospital. She was in the emergency room, and so their estimated needs at that time were not calculated. However, the patient's medical plan was not working, and therefore the patient had to be admitted to the ICU. At this time, the patient was immediately intubated and therefore ventilator dependent. According to the nutrition care manual, with intubated patients, the most appropriate estimated energy need calculation is the Penn State equation, which is shown on this slide. The Penn State equation needs to be calculated daily to meet changes in ventilator settings as well as body temperature. On 2/18, during the patient's initial nutrition assessment, the patient's Penn State equation calculated her calorie needs to be 1,217 calories. During the patient's total admission, her Penn State equation ranged from 1,200 calories to 1,400 calories. For the patient's estimated protein needs, there was no visible pressure ulcers, and the patient was not on dialysis. Therefore, Winter Park's protocol for protein is 1 to 1.2 grams per kilogram adjusted body weight, which calculated her protein needs to be 55 to 66 grams per day. As for the patient's estimated fluid needs, 1 milliliter per kcal would be sufficient. When the patient was admitted to the ICU, her initial treatment plan was changed, and the patient was seen for the following reasons. The patient would be intubated and therefore ventilator dependent, as well as the patient would be started on Endotool for blood glucose sugar control. The patient was started on titrating pressors, and there was going to be a solution for her acute kidney injury. The patient needed treatment for her elevated ammonia levels, as well as a nutrition consult for tube feeding management. Looking at the patient's initial laboratory and medicinal information, the patient's biochemical labs were pretty normal, except for the patient was showing signs of acute kidney injury, as well as the patient's ammonia levels were elevated, and the patient's blood glucose levels were slightly elevated, showing an A1C of 8.5. As well as for the first medicine dosages, the patient was started on an ergocalciferol for her vitamin D deficiency, Protonix for her GERD, Dialod for her narcotic pain relief, Ativan for anxiety, normal saline for hydration, D10, and Endotool. When the patient was admitted to the ICU, the doctors consulted nutrition for a nutrition support consult for tube feeding. The patient was started on osmolite 1.5 at 40 milliliters per hour, infused over 22 hours. Winter Park has a protocol to infuse over 22 hours versus 24 hours because there's always time where the patient might not be on the tube feeding for treatment or for surgery, or just because they're changing the tube feeding formula. There's many reasons, so that's why the tube feeding formula is estimated to be infused over 22 hours. Osmolite was chosen versus other formulas often considered in the ICU because the patient was not appropriate for Oxeba, the patient was not considered to be septic or have ALI or ARDS, the patient also did not need increased protein needs, and therefore Promote was not an appropriate formula. At this moment in time, the patient's GI tract seemed to be functioning well, as there was no indication of diarrhea or abdominal distension. Therefore, osmolite 1.5 was chosen for the patient because patients that are ventilated are often on a fiber-free formula, and osmolite 1.5 is without fiber. The patient's first nutrition problem and intervention. At first, the problem was the patient was consuming inadequate protein energy intake. This was because the patient was NPO for several days before the patient was consulted for tube feeding management. The etiology was decreased ability to consume sufficient energy or protein secondary to intubation, and the patient showed signs of estimated intake less than recommended levels secondary to NPO status on the ventilator. For our goal, the patient would meet estimated nutrient needs via her EN nutrition or tube feeding. To follow up with this tube feeding management, on 2/24, nephrology ordered tube feeding order from osmolite to Nepro, which is a renal formula to solve for the patient's acute kidney injury. However, the patient never received Nepro because the tube feeding was held for high gastric residual volumes, around 750 milliliters. The patient was receiving her tube feeding through an NG tube ending in the stomach. The patient's new prescription was written for Nepro. However, as I said, the patient never received this formula. The patient's new goal and intervention comments for this change was the tube feeding was hold for high gastric residuals due to a possible hernia or ileus. Nephrology was now overseeing tube feeding management for Nepro versus osmolite 1.5. However, nutrition recommended to resume EN nutrition as soon as possible and to change the formula from a fiber-restricted formula while on pressors. And also a lower fat formula to help with the high gastric residuals. The patient was found to have an ileus. An ileus is a temporary absence of normal contractible movements of the intestinal wall, and this is diagnosed with a CT scan. The patient showed signs of abdominal bloating, nausea, vomiting, severe constipation, and loss of appetite. Treatment for ileus: an NG tube is passed through the stomach or the small intestine to relieve pressure and distension, as well as a rectal tube is passed into the large intestine to relieve pressure as well. As for diet with patients with an ileus, a post-pyloric feeding tube is recommended, or TPN nutrition is also recommended for nutrition in the ileus patients because gastric feedings can worsen the ileus. As for Mrs. R's medical plan after the patient was positive for an ileus, she would receive TPN instead of EN nutrition, and GI was consulted to correct the ileus. She had a CT of the abdomen, was still on the ventilator and sedated, and the patient was still on Endotool. Total parenteral nutrition. This is a supplement nutrition of dextrose and amino acid solution given intravenously, often considered for compromised GI tract patients, which include patients with an ileus. There also include patients with ulcerative colitis, bowel obstructions, pediatric GI disorders, and short bowel syndrome. The solution are individually calculated per patient's current medical status, and it's a combination of dextrose or carbohydrates, amino acids, which are proteins, lipids, electrolytes, and fluids. For Mrs. R, her TPN order was monitored by pharmacy in Winter Park Hospital. This TPN would go at 70 milliliters per hour via a PICC line with half normal saline. The patient's calorie goal was 1152 to 1440 calories per day, with a higher protein goal than what nutrition consulted for. This protein goal was 72 to 101 grams per day. And so the TPN order was 15% amino acid concentration, 70% dextrose concentration, 20% lipid concentration of a total volume of 1,680 milliliters.